we started, vascular clinic and collaborated with general surgeons, vascular surgeons to start doing more endovascular and CLI work, and also aortic work. We started the endograft for the abdominal aorta and thoracic aorta.
I feel like, we were talking about this in an earlier conversation, but there's certain procedures where there's like something that affects him every single day. Prostate, like that guy is reminded every day multiple times that he has this. And when you can give him relief in a day and they can go back to normal, it's just amazing to watch that.
That fellowship was pretty cool. And the reason I chose Yale because it was a combined vascular surgery and IR combined fellowship.
I am here with Dr. Golewale from NG Vascular in Chicagoland in Indiana. And doctor, how did you get to the IR space?
Yeah, so when I started my residency, I wanted to be a surgeon. So I wanted to be a vascular surgeon, or always interested in doing stuff with my hands. Through my surgical residency, I was seeing all these cool endovascular procedures performed by interventional radiologists. And that was kind of a unique specialty that I saw that I kind of knew right away that this will be the future of medicine. So then I quickly switched my specialty from surgery to radiology just to do endovascular surgery or interventional radiology.
Now, did you do the traditional path of hospital into where you kind of are now?
Yeah, so after the training, and then I went to Yale for my endovascular interventional radiology training. That fellowship was pretty cool. And the reason I chose Yale because it was a combined vascular surgery and IR combined fellowship. So we went through some open surgical procedures in the OR with vascular surgeons, and of course did all the endovascular stuff and embolotherapy in the interventional radiology.
And so how long have you been practicing in the IR space now?
For about 13 years.
Okay, so you've seen it change a lot over the last 13 years too.
Yes, yeah. So I went with a traditional DR-IR group for first 8 or 9 years in Indiana, northern Indiana, very close to Chicago. At that time, I was always interested in the vascular world, so I started a IR clinic, vascular clinic for radiology department, and the IR department was very slow with all of these high-end cases. They were mainly doing biopsies, drainages, more routine IR cases. Then I brought the idea of the IR clinic to the department. We started, vascular clinic and collaborated with general surgeons, vascular surgeons to start doing more endovascular and CLI work, and also aortic work. We started the endograft for the abdominal aorta and thoracic aorta. So after that 9 years of spending time in the hospital, during that time towards, I think around 7th year when I knew the idea of the outpatient IR, I think OEIS was its initial stages. I think that was probably their second or third conference. There was in, I believe there was in Vegas. And I came to the conference and I met with some smart people here, and
a lot of them here.
Yeah, a lot of them here, and I got very good mentorship from some of them, and I thought that this is something I would like to do, and I think I would enjoy to do. And the reason I jumped on the outpatient OBL work because I can do what I like to do and not just do hospital, routine cases.
So let's talk about that shift from the hospital to the OBL space. Obviously it's medical training, Yale-trained, all this stuff. Now you're a small business owner. How was that education shift for you?
Yeah, it was a significant shift. I did not know anything how to run a business, how to run a clinic. Even though we had hospital-based clinic, it was not an outpatient clinic like we have in OBL setting. So it was a lot of learning, a lot of researching, a lot of talking to other doctors who are doing this, visiting their centers to see how they do it. And then you figure out as you go along, a lot of things, we're still learning, things are changing, the regulations change, the policies change. There was a big shift with the clinic. I always enjoyed talking to patients, the families, and I know some some radiologists, especially or IRs, they shy away from, having a lot of patient contact. But I always enjoyed, speaking and educating patients. So that was my thing, like, hey, I want to educate, spend time with the patient and have patient decide with me, like, what the treatment options are there.
Now, being in your Chicago and Indiana practices, what are you seeing in the majority of cases? Like, what type of procedures are you doing?
I'm heavy in endovascular revascularization. That always been my passion from beginning of my career. So I do a lot of PAD and CLI work. I enjoy doing opening arteries in their legs, feet, going all the way into the pedal plantar loop and reconstructing those arteries. And of course, with my IR training, I always also enjoyed the embolotherapy, embolizations. So we do a variety of embolizations for prostate, for knees, and MSK embolization for fibroids. Some tumors, also we do some oncology work. Yeah, so among embolizations, I enjoy the most prostates. I think that gives a lot of satisfaction talking to the guys, and I think they're very appreciative of what we do for them.
I feel like, we were talking about this at an earlier conversation, but there's certain procedures where there's like something that affects him every single day. Prostate, like that guy is reminded every day multiple times that he has this. So when you give him relief in a day and they can go back to normal, it's just amazing to watch that.
Of course, yeah. I think a lot of these guys are not told what other options are there. They have been put on medications, which half of the time does not work, or they have a lot of side effects with it. They're also suffering from ED. That's also a very common side effect of some medications. Plus, before that, they may also have those symptoms. And then they are tired throughout the day because of nocturia they had night before. They woke up like 5 times. And they cannot enjoy their life. They could be on golf course, but they have to run to the bathroom, every 10 minutes like that. So giving them the option that, hey, we are not drilling anything through your penis to shave the prostate, but we can go through a small artery with an IV in your wrist or in your upper thigh and shrink that prostate back to the normal size. That gives them a hope. And then when they achieve those results, they are very appreciative of that.
Well, I think that's that thing is the guys sit there and they're mentally, because we do a lot of ads for PA, and they're thinking about, if I get this taken care of, I'm going to have this area cut or chopped or injected, and I think that puts it off. And when you guys come to them and say that, like, you could leave your pants on if you really wanted to, and it would still get the job done. That's what's so amazing about IR.
Yes.
In the last year, like, when you think about all the patients you treated and done post-ops and stuff, who's the person that stands out that you're like, this person's life has changed?
Yeah, I mean, several patients that come to my mind, especially people who were told that you would need amputation, you had no other option. They came in, either they looked us up online or family member told them that their experience, what they had at NG Vascular and Vein, or the doctors, they're like, hey, can you do something about this patient? There's no other option. We would have to amputate their leg. And numerous times we have been able to successfully open up those clogged arteries in their calf and feet and got their wound healed up. So that really, gives me that happiness that I'm able to save someone's leg. And of course, for a patient to have, both legs intact and able to walk again, that's a big deal for them.
It's crazy to think that, you can go in and if half an hour, 40 minutes, save a limb, when they probably, if they just gone to the hospital, it would have been gone. Like, that's just amazing to me. And
yeah, so unfortunately, it has come to a point that some of the doctors now telling these patients, like, do not go to hospital with these gangrene or these non-healing wounds, because the first thing the ER does is call orthopod, and what the only thing they know is chop their leg. They want to get rid of the side where they're strong.
Those orthopods, they gotta hit the action.
Exactly. Yeah. So the research has shown that most of these patients who are getting amputations, they were not offered angiogram. Most of them are not a bypass candidate because they have distal disease, tibial disease, small vessel disease, or they have other comorbidities. They may not be anesthesia candidate. But there are not that many specialists out there who may call themselves as a vascular specialist, but they're not doing a below knee work, for example, or CLI work. But some who can do it, who can help the patient, they definitely needs help. Those patients have hope.
Have you ever spoken to, I think it's Karen at the Global PAD Awareness Association? Have you met with her before?
Yes.
She's just so passionate about it. She even she'll get on the phone with them when they're at the hosptal and talk to the doctor. Like, I love that.
Yes, I follow her on LinkedIn. She does a lot of cool posts, and I think she has been a spokesperson for these patients. I think her program has saved majority, a lot of patients.
She was saying there like 1,000 legs, their limbs, because they've literally said, like, nope, don't go there, go somewhere else.
Yeah.
So the really important question I think everyone wants to know is, you're in Chicago. Is it Malnati's or Giordano's?
Okay. I love Giordano's.
What? No. Well, doctor, I really appreciate you being on. Thank you so much for all the work you do.
Thank you, Justin.
Appreciate you.
Thank you.